to the Doctor Is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California. Thank you very much for joining us. Today I am delighted to welcome as my guest the distinguished pathologist, board-certified pathologist, Dr. Hugh Wilson. Dr. Wilson, thanks for joining us.
Happy to be here, Dr. Morwood.
Dr. Wilson, you've been on the program before, and we appreciate you coming by and teaching us so much. Today we're going to talk about infections, and more specifically, we're going to talk about something that the public doesn't hear a lot about, and that's fungal infections. So before we get to that relatively uncommon fungal infection, Dr. Wilson, could we back up and just summarize what we mean by a bacterial infection and what we mean by a viral infection, and then that'll segue us into fungal infections.
Well, if you recall back to the days when you and I were biology students in college, we said there were three kingdoms, right, of life. There were the bacteria, the plants, and the animals, right? And then somewhere lurking out there were the viruses, because theoretical biologists aren't really sure if they're alive or not. So they kind of have this sort of category off to themselves by the side. Nowadays, now that we can sequence DNA, the theoretical biologists tell us that there are six. I'm going to stick with the first three.
So theoretical biologists tell us that there's actually 6 different life forms?
Yes.
On Earth?
Yes.
Now see, Dr. Wilson, every time you come on this program, I learn a lot. Can we summarize that? I've heard of prions, right?
Yes.
Now is prion sort of just a snip of DNA, and we're not sure if that is alive, but
Exactly.
it can replicate?
So, you know, the three basic functions of life, right, are the ability to consume energy, produce waste, and reproduce. Now, viruses and prions cannot do any of those three functions by themselves. They have to get inside the cell of another organism, and then they subvert the mechanisms of that other organism and to do those things for them. So the question is, are they really alive, or are they a carry-on?
Okay.
So aside from those,
sort of a piggyback.
Yeah, they piggyback
organism.
on. Right.
Okay, but certainly we know about bacteria. Everyone probably has heard of staph and strep. People get staphylococcus. And in fact, there are many different types of staph, and every human being has staph on their skin, and that doesn't
Correct.
mean they're infected. It's just colonized there.
Exactly, they're
Right.
populated. It's called, in bacteriology, we call that the normal flora. So there's normal flora of the skin, and there are normal flora of the upper airways, and there's normal flora of the GI tract, because the GI tract is not sealed off from the outside world, right? It's open at the mouth and at the anus. So it communicates with the outside world and all those bacteria.
Okay, so for example, common in the colon is E. coli.
Correct.
And we need E. coli, right? It serves a function.
Correct.
It helps synthesize some vitamins and process some food and the waste, etc. So it's not. So we're in contact with bacteria all the time, and our bioflora is significant, and it's oftentimes helpful. But when does that bacteria become invasive or unhelpful, causing an infection?
Typically in a couple of situations. One where you have a bacterium in the wrong place. The bacteria that live in the colon don't do well on the skin. We can deal with the normal staph and strep that live on the skin and in the upper airways. Even small breaks in the skin don't typically turn into a staph infection. They can, but not typically. But if you were to have E. coli or Proteus or Pseudomonas, one of those colon organisms in the skin where they shouldn't be, that's a big problem.
Okay.
And then the other time when a normal flora bacterium can cause an infection is when we have a problem. The bacterium is normal, but we have a break in the skin, we have some other illness, something that compromises our defenses, because you know skin is our biggest defense,
Right.
that then results in a bacterial infection.
Okay, so commonly people, if we say it's a bacterial infection, it can be staph or strep, rarely, or it can happen, enterococcus, enterobacter,
Yes.
etc.
Enterococcus, yeah.
But those are all well-known, described bacteria and infections, and in fact most of them respond to antibiotics. Isn't that correct?
Yes, that's correct. There is an emergence of bacterial resistance over time, but so far, fortunately, our pharmacologist friends have been smart enough to come up with antibiotics that can treat even the resistant organisms or combinations of antibiotics.
Okay. So, actually, Dr. Wilson, please come back again and we'll talk more in depth about bacterial infections. But the second group that we want to summarize, mention briefly, are viral infections, correct? Now, when we talk about the common cold, isn't that caused by a virus that's not a bacteria?
That's correct. And so viruses, bacteria can do those three things. Bacteria can consume energy, produce waste, and reproduce themselves. They're different than human cells and plant cells, but they can do those three things, which viruses can't. But viruses, if they contact you, they can get in, they have this ability to sort of open a door into a human cell, and also plants and animals. There are plant viruses and fish viruses, and they're ubiquitous. But they can get inside the cell, and then I liken them to a little terrorist, because it then takes over your mechanisms for making energy and for reproduction and tells your cell to reproduce me, the virus.
Okay, so is it true that the virus is like a strand of DNA?
Yes.
It can insert its own DNA sequence into the DNA of another cell.
That's correct.
And that way, when the cell reproduces, the viral DNA sequence is reproduced.
Correct.
Now, before we go on, Dr. Wilson, this stuff is so fascinating to me, and you're always teaching me a lot. But haven't some viruses been implicated in cancers? For example, if a virus inserts itself into the cell in the lining of the colon, and that cell starts to replicate itself, hasn't that been implicated in cancer?
Yes. So human papillomavirus in cancers of the head and neck, and also the female cervix, and then also the virus that causes mononucleosis,
Right.
has been involved in the pathogenesis of some lymphomas.
Right.
And so, there are viruses, and those are called, they're called oncoviruses, and once the viral DNA is inserted into the human DNA, it's called an oncogene.
Okay.
So there are viruses that are thought to contribute to the development of cancer in multiple sites.
Okay, so we've summarized bacterial infection: Staphylococcus, Streptococcus, rarely Enterococcus or Enterobacter. We know that there's a normal bioflora. E. coli is in our gut, in our colon. Our skin is covered with staph. And then you summarized very well for us viruses. That's the cause of the common cold, of course. And the virus needs to get into a cell and then take over the reproductive system of the cell so its own DNA sequence gets replicated, correct?
Correct.
Okay.
For example, in the laboratory, if I may interrupt you for just a second, we can take a bacterium and we can put it on a plate of just agar, right, and a few nutrients, but no cells, and the bacterium will grow there. If you put a virus on that same agar plate, it won't grow. You have to put the viruses into a cell culture to make them grow.
Got it. Okay. So a virus needs another cell. It inserts itself into it, its own DNA sequence, and takes over that replication.
Yes.
Okay. So, which leads us to our topic today. There's a whole other group of microbes that cause infection, and that's fungi.
That's correct.
Now, Dr. Wilson, before we go on, you're a fan of gourmet food. Now, mushrooms are fungus,
Yes,
or are fungi, correct?
Yeah, they are.
But they don't cause infections.
Correct.
In fact, although there are some poisonous mushrooms, we are delighted to eat mushrooms, correct?
There's nothing better than truffles. So
Right.
most fungi, I say fungi, some people say fungi,
Okay.
it's a difference. So it's interesting, fungus, the adjective is fungal, and then the plural can be either fungi or fungi.
Okay.
I'm not an entomologist. But yes, most of them are completely harmless. There are only a few that tend to cause illness.
Okay. So how do we better describe or define fungi? Do they reproduce themselves? Is it like a plant? Is it invasive? Are there fungi everywhere, like there are bacteria everywhere?
They're quite ubiquitous. They're different than bacteria in that bacteria, for example, have a cell wall, but they don't form a nucleus. So plants, animals, and fungi, they do have a nucleus, as opposed to bacteria. So the bacteria are called prokaryotes, the others are called eukaryotes. Animals do not have a cell wall. Plants and fungi do. So they're eukaryotes, but with a cell wall. And yes, they can. They can consume energy, produce waste, and reproduce themselves just like a plant or an animal can.
That's fungi.
Yes.
Okay. So how and why, how do they go about causing an infection, say, in a human being?
Most often it's because their reproductive form, like the mushroom is the fruiting body of a fungus, the mushroom forms spores, right? Those spores are often airborne and can be inhaled. And when fungi do cause infection, that's the typical route. And of course, living here in California, I think everybody's probably heard of valley fever, sometimes called San Joaquin Valley fever.
Right.
And that's the very common one here in the Salinas Valley especially. And it's transmitted by inhalation of spores.
Okay. So if we define an infection as the abnormal invasion by a microbe that is not supposed to be there, invading into the tissue, is that the same as a fungal infection?
Yes.
Okay. So are things like tuberculosis, is that a fungal infection? And onychomycosis, that's the scientific name for a fungal infection of the toenails.
Correct.
Isn't that correct?
Yes. Tuberculosis is an odd organism. It's not a fungus, but it's not really a bacteria. It's called a mycobacterium. It's somewhere in between. But the onychomycosis that you mentioned it's a fungus. It's a fungal infection. So, for example, fungal infections of the skin, ringworm, right? If they which we call tinea corporis. If it's on the scalp, it's tinea capitis. But if in the fingernails, for some reason or another, it's called onychomycosis. But yeah, those are fungal infections.
Okay, so Dr. Wilson, what we commonly call athlete's foot or jock rash.
Yes.
Now, is that a fungal infection?
Yes.
Okay, so how or why does fungus that may be everywhere, how does that cause an abnormal contamination or colonization or infection? But for example, we might think that all around a locker room, whether it's the guys' locker room or the girls' locker room in high school, say, I suppose the fungus is all over the place.
Correct.
But not everybody gets athlete's foot, and it doesn't happen year round. So how is it? What are the circumstances that lead to a fungal infection?
Increased moisture in particular. Fungi love moisture. They love moist environments. So often the deciding factor between someone who gets it and someone who doesn't, even though both people have been exposed, is how well they dry off after their shower. Believe it or not, it's something that simple. If the folds of your skin, wherever they are, remain moist, it's a good growing ground for the fungi.
Okay, so I remember back in CYO basketball in the 6th and 7th and 8th grade, our coach admonished us to take the towel and dry between the toes very well.
Yes.
Correct?
Yes. And powder, right? Some coaches will also recommend using powder on your feet because that also dries them.
Okay. So similar to a plant, we know certain plants need the right soil and fertilizer and sunlight and water. Fungus need certain circumstances and a certain milieu to invade or thrive or reproduce. Isn't that correct?
And they're particularly sensitive to that humidity. That high moisture content is particularly important.
Okay. So Dr. Wilson, you mentioned specifically valley fever. Now, is that coccidiomycosis?
Correct.
Okay. So, as an aside, there was a plastic surgery chief resident who published a paper on direct inoculation of coccidiomycosis in a car accident, as a unfortunate little boy was tossed out of the car into some sand, and on the side of a hill there was some coccidiomycosis that directly inoculated the skull, leading to an osteomyelitis.
Wow.
That chief resident was, in fact, David Morwood. So we published that paper from Children's Hospital, Los Angeles, with Dr. Larry Nichter. So a fungus can actually get inside the tissue and invade, correct?
Just like a bacterium, if the skin defense mechanisms, the number one being the mechanical integrity of the skin is a huge barrier to infection, and if that mechanical integrity is disrupted, that can lead to an infection. Yes.
Okay, so Dr. Wilson, we talked about, in summary, a bacterial infection, staph and strep, etc., responding to antibiotics. For the common cold, there's not really an antiviral agent. There are some newer antiviral agents like famvir, famciclovir, for certain herpetic infections.
Correct.
Now, there is a Tamiflu, I think.
Yes.
Now, that can slow down and stop some viral reproductions, etc., right?
Particularly influenza.
Influenza. Okay. Now, if someone is unfortunate enough to get a fungal infection, what do we do about that? What can doctors do?
So there are antifungals, and when I was in my early training days, pretty much the only one was a drug called amphotericin, and it had so many side effects, we called it amphoterrible. And we only used it for deep, life-threatening fungal infections, and not anything that wasn't life-threatening, because the side effects were likely to be worse than the disease itself. But now we have the conazoles, ketoconazole, fluconazole. Those are about as effective as amphotericin, but far less side effects. So it's much easier to treat fungal infections now than it was 20 years ago.
Okay. Now, Dr. Wilson, we mentioned what's commonly caused as athlete's foot. Men and women can get that.
Yes.
Jock rash. Typically, we talk about a male athlete getting that.
Right.
But women can get a yeast infection.
Correct.
Right? Now, is a yeast infection a fungal infection?
It is, but what it is for example, there's normal flora in the vagina as well. Any part of the body that's open to the outside world is going to have normal flora. The vagina is normally a mixture of bacteria and yeast is a form of a fungus. If that balance is changed, typically the most common situation you'll hear about is if a woman's taking antibiotics, which kill off a lot of the bacteria. It allows an overgrowth of the normal yeast that are normally there, but they overgrow.
Okay, so that's why sometimes I have women patients who tell me, Dr. Morwood, if you're going to give me antibiotics, then I should also get a treatment for yeast infection.
Correct.
Just to prophylax that overgrowth of the yeast. Isn't that correct?
Yes. Some women know that every time they take antibiotics, it happens to them.
Okay,
but it's variable. Everybody's different.
Okay. Now, what about the more serious infections like valley fever? You talked about coccidiomycosis. Now, can't that get into the lungs,
It
et
sure
cetera?
can. It sure can.
And that's a problem.
It can be very serious. It's interesting, though, that it's estimated that about 60% of the people who have been exposed to valley fever at some time in their life, and you can tell that by doing a blood test for antibodies. Remember, antibodies are the reaction to an organism. About 60% of the people who have antibodies to valley fever, meaning they have been exposed, have no recollection of ever having been sick. And about 40% of them say, well, I had a flu one time and I didn't know what, I had a flu-like syndrome, but it was very strange and I had joint aches but then it went away. It's estimated that only about 5% of people who get exposed actually get a pneumonia. But it's a very serious pneumonia. And then it can also, in about 1% of patients, it can spread to other locations. Lymph nodes, but it can spread to other organs and even to bone and cause fractures.
Wow, sounds like it's serious.
It can be very.
So, in summary, Dr. Wilson, we talked about bacterial infections. We talked briefly about viral infections. We have received an introduction to fungal infections. We talked about yeast and jock rash and athlete's foot, etc. And we've mentioned that they're thankfully, now better treatments for fungal infections.
Yes.
Dr. Hugh Wilson, you're an excellent teacher. I hope you come back again. Every time you're on the program, I learn a lot. Thanks for being here.
I'd love to come back.
Excellent. Once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon right here on the beautiful central coast of California. We're going to take a very brief pause for a very good cause. I hope you will stay with us.
It's scary making the decision to have reconstructive surgery, but it's so worth what you get out of it.
I'm stress-free. I know I'm not going to get breast cancer.
Everything is back to normal, and it really did not take long to bounce back.
I have a sense of hope for other women that this surgery can help them to live normal lives.
This year, more than 200,000 women in this country will be diagnosed with breast cancer. For many of them, a mastectomy or removal of the affected breast will be recommended as part of the cancer treatment.
The idea of losing a breast for some women can be almost as difficult as being diagnosed with breast cancer. Modern breast reconstruction can help. The purpose of this presentation is to provide women with valuable information about the major issues in breast reconstruction.
We'll have an opportunity to speak with women who chose different methods of reconstruction. We'll talk to experts in the field of breast cancer, and we'll let you know your options for breast reconstruction.
I embraced the mastectomy and reconstruction procedure, and because of that, I had a terrific outcome, and it's changed my life in a positive way.
For the thousands of women who will be diagnosed with breast cancer this year, we understand this is most likely a troubling and frustrating time. We hope this presentation's been valuable to you and will help you make some very difficult decisions that you're facing.
Welcome back to the Doctor is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon here in beautiful Monterey, California. Thank you very much for being here. Today, in this segment, I'd like to discuss and answer and address one of the most frequently asked questions I hear in my office, and sometimes when people are considering a consultation. And that question is it possible that I can have an isolated neck lift? Can I have only a neck and jowl lift, or do I have to have a facelift as well? This is one of my favorite questions because I think that there are other plastic surgeons that disagree with me, and that's okay. In my practice, rest assured, I can tell you with some assurance, I can guarantee you that in my practice, in my office, you can get a natural neck lift or a neck and jowl lift, and you do not have to have a facelift. I'd like to be clear about that. So let me back up for a moment and talk more about what a natural neck lift is. I'm going to talk briefly about what a facelift is, although no one really knows what a facelift is. It can be so many different things. And then we're going to talk about the differences and why in my practice you can have an isolated neck lift or a neck and jowl lift and you don't have to have a facelift. First of all, the natural neck lift is a system of analysis. It's not one operation or one treatment. It's a system of analysis looking at your anatomy, your medical history, looking at your expectations and your desires, and then going through a custom design approach system, developing a plan for you to leave a natural appearing result. Once again, it's a system of analysis. That's the natural neck lift. And as I mentioned, the natural neck lift can be accompanied by a jowl lift. Neck and jowl lift is something I do more commonly, I think, than an isolated neck lift. But if you'd like to have just a neck lift, that's what you can have. Now, a facelift, of course, elevates the soft tissues above the mouth, or as we say, plastic surgeons say, cranial to the mouth. In other words, the neck and jowls we consider to be the lower third of the face. The cheeks, that's the mid-face going up to the lower lids. And then, of course, the upper third of the face, that's the upper eyelids, the brows, and the forehead and the hairline. So typically, when we discuss facial rejuvenation surgically, we look at the face in thirds. The upper third of the face is the hairline, the forehead, the eyebrows, and the upper lids. The mid-face, that's the lower lid area, and the cheeks, nasolabial folds, I would say down to the mouth or the lips. The lower third of the face, the neck and jowls. So, why is it that some plastic surgeons, I've heard, I understand, tell their patients that they cannot have an isolated neck and jowl lift, they have to have a facelift along with it. Well, it all depends, in my practice, it all depends on what the patient wants. If a patient comes in and says to me they don't want to change their face, but they would like their neck firmed up and they want a cleaner, crisper, firmer, better defined chin, jaw, and neckline, well, the incisions for that operation to me, in my practice, are different than if someone comes in and says that they feel their cheeks are sagging, their nasolabial folds are heavy, the corners of their mouth look kind of droopy, their malar area, the so-called arches, high arches of the face, they seem to be sagging. So those incisions are slightly different. So if someone wants a facelift, again, that's a custom designed approach. No one really knows what a complete facelift is anymore. It could include the eyes, it could include the lateral brow elevation, sometimes it includes the forehead, it can include the cheeks and nasolabial folds and neck and jowls. Sometimes, to some people, a complete facelift includes the nose. So what I like to do, of course, and what I advocate in my office is a custom designed approach. We offer what I call a component facial rejuvenation. We lift and fill. I believe in volumetric restoration. You've heard me talk about the triangle of beauty or triangle of facial rejuvenation. The skin, volume changes, and soft tissue position and repositioning. Those are the three parts of the triangle. The triangle of beauty, the triangle of facial rejuvenation. So we can use all three of those components to perform facial rejuvenation. Now, if someone comes into my office and they say they want a complete facelift, well, my advice to that person is, a man or a woman, that we look in a mirror together. We look at photographs of them that I can take together. Let's look at photographs from decades prior, and let's look at the vector computer imager. Take your image and process it through the vector computer imager, and then we sit down, and instead of just calling it a complete facelift, let's discuss more specifically, what is it that you want to change? Do you want to change your forehead? Do you want to change your eyebrow, your upper and lower eyelids, your cheeks, your malar areas? Do you feel like you've lost your high cheekbones? Do you feel like your nasolabial folds are too heavy? What about your neck and jowls? So we can do component analysis, and again, leading to a custom designed approach for you, because everyone ages differently, everyone's faces differently, not everyone wants the same thing. So in my practice, you can have your eyes done by themselves. You can have your brows elevated if you want by themselves, cheek elevation, neck and jowl only, etc. So the incisions, however, are different. So for example, if someone wants just their cheeks elevated, lower cheeks elevated, usually I carry the incision up from the earlobe in front of the ear or right along the cartilage up into the so-called sideburn or temporal tuft. For women, we call it the temporal tuft of hair, and in men it's the sideburn. I carry that incision up into that area and sometimes up into the temple area. That way, we can elevate the tissue safely, get proper exposure, redrape the skin, elevate the skin. What I like to do is more reposition the skin, elevation and lifting rather than simply to remove it. If I find that if too much skin is removed, if there's too much pulling, that tends to give a tight, unnatural sort of done look, whereas we want volumetric restoration. We want the face to project. A projecting full face is a youthful face. So, in general, the facelift incisions, cheek lift incisions, tend to go higher up right at that edge where the ear meets the cheek, up into the temporal tuft of hair, the sideburn, oftentimes into the temple. And then, if we're also going to do the neck and jowls, the incision goes under and around the earlobes to the crease in the back of the ear, across that mastoid bone in back of the ear, and then into that hairline, the mastoid hairline. Oftentimes the neck and jowl lift is accompanied by a short curvilinear incision or curved incision in the submental crease. I find that about 90% of Americans, or 80% of Americans who come into my office already have a scar under their chin. it's because their little brother pushed them down the stairs, or they fell from their bike or tripped on the curb, etc. So they already have a scar there. So those incisions, we can use some of them, we can extend them, sometimes we shorten them to gain access to the areas where we want to affect, where we want to lift, where we want to reposition, where we want to elevate. So let's keep in mind, as I said, volumetric restoration. Oftentimes I'll recommend addressing the volume portion of the triangle. So for example, if we're going to talk about the triangle of facial rejuvenation or the triangle of beauty, again, there's the skin, that's texture, that's chemical peels and laser and skincare and resurfacing. Then there's volume changes. As you know, as we mature, we tend to lose fat in the face and in the hands, and we gain that fat in the trunk. It's an unfunny practical joke. And then there's the soft tissue position. Has it descended? Does it need to be repositioned, etc.? And of course, that triangle rests upon a foundation. That's the craniofacial foundation. That's the skeleton, the actual foundation of the soft tissues of the face. Sometimes we bring the chin forward. Sometimes we will augment the cheekbones. You've all heard of the expression high cheekbones of a model. So that's a desirable characteristic. We want to have a volumetric restoration. We want to lift and fill, not just pull and remove the extra skin. So, back to the question, can I have a neck lift without having a facelift? Rest assured you can in my practice. What's that like? First of all, most neck lifts, if we're going to do a submental platysmoplasty or address the tissues underneath the chin in this anterior part of the neck, they're going to get that a curvilinear incision or curved incision in the submental crease. And it's been my experience in over 20 years of plastic surgery, hardly anyone ever is concerned about that scar. It tends to fade very well. The scar is seen only in what we call the worm's eye view. In other words, if someone is looking from your feet or from the ground up, sometimes they can see it. But face on or from the side, in general, that submental incision is not visible. But through that incision, I can sculpt the fat, I can address the lax muscles, those bands that some people get. Sometimes people come in and they say they want a waddleectomy or they want the turkey neck correction procedure. Most of that is done through a submental incision. So I can gain access, I can sculpt the fat, remove some fat, I can address that loose muscle, I can tighten it up. Sometimes I divide those bands. And then from those periauricular or incisions around the ears, starting at approximately the tragus is this little piece of cartilage here. Starting there, I can go down to the earlobe, under and around the earlobe, across that mastoid, and into the hairline. Through those incisions, then we can do the neck lift only, or we can do the neck and jowl lift, depending on what a person needs. One of the key elements of a platysmoplasty, there are many types of platysmoplasties, is to recreate a tight sort of hammock, a sling that goes almost from ear to ear. We want that muscle, that platysma muscle, to restore the cervical mental angle. That's the bend, or that's the angle underneath the chin that reflects a youthful, very beautiful neck and jaw and chin line. So oftentimes the fat seems to accumulate in that area, the muscle gets lax, the skin can get lax, there can be too much skin, and we need to address each of those components. There's also something called subplatysmal remodeling or subplatysmoplasty. That should be done very gingerly, because under the platysma muscle, let me back up for a moment. The platysma muscle is a very broad fan-shaped muscle that comes from the lower part of the jaw, the mandible, down to about the clavicles. And in our species, it's vestigial. It's very much like the appendix. It has lost its function. The only remaining function that I know of, it just gives plastic surgeons work. So we're grateful for that. But if we compare that to, say, the horse, the horse has that huge jaw, that very long mandible. The platysma muscle in the horse runs about 3/4 of the way down the body, and it's the shivering muscle. That's how the horse shivers and shakes off the flies. So in our species, as I said, it has no function except to reinforce the soft tissues, those deeper structures in the neck. There's something called the superficial cervical fascia that keeps the platysma muscle in place. With time, of course, that connective tissue gets lax and the platysma muscle can droop. For early platysmal banding, when we have just a little bit of banding underneath the chin at that anterior part of the neck, Botox, botulinum toxin, can make those tight muscles relax and the muscles can fall back, restoring the cervical mental angle. I talked about the fat. I talked about the skin. Now, I do want to go back to that topic, as I said, subplatysmal remodeling or submental platysmoplasty. Underneath the platysma muscle, there's fat, and there are also glands. They help to make the spit. They're the lymph nodes and salivary glands, minor salivary glands, major salivary glands. There's some paired submaxillary glands underneath here of the corners on the sides of the Adam's apple, and they can show in some people whether or not they have a platysmoplasty. So what we need to do is keep in mind, even if we firm up the soft tissues of the neck to recreate that sling and deepen the cervical mental angle, sometimes those submandibular glands show, and that's a normal structure. Now, I talked about subplatysmal surgery. We can sculpt that fat, remove that fat in a conservative fashion. Some people advocate shaving down the submaxillary glands or even removing the submaxillary glands. That's an uncommon, rare procedure in my practice because I think that being able to make the saliva under the tongue is a desirable thing. We don't want to give people dry mouth. Some of that fullness is natural. I think if we take out too much fat, take out too much of that glandular tissue, if we take out too much of the salivary gland tissue, then it gives a kind of a cachectic, unnatural look. It makes that submental or cervical mental angle too sharp. And what we're trying to do is give a natural result, a natural looking, clean, crisp, firm neckline for a natural neck lift or a neck and jowl lift. On occasion, I will, in a conservative fashion, shave down those glands if they're quite large, but in general, I'm not an advocate of removing the glands. And of course, if we're going to do some subplatysmal surgery, the patient has to be aware that there are very important nerves, arteries and vessels, arteries and veins deep to the platysmal muscle, so we have to be aware of that. There is some risk to going into those planes. We do know our anatomy very well. On occasion, there can be a variation in the nerve. For example, the marginal mandibular nerve. That's the nerve that comes out from behind the ear under the platysma muscle, and it innervates the muscles of the chin and corners of the mouth. And so sometimes people can get a crooked smile, etc. Sometimes they can show their lower teeth only in a different way compared to before surgery. Now, I do want my patients to know that temporary asymmetries, having a temporary crooked smile, temporarily being able to only make a sort of a different purse of the lips, I'd say that's very common. Sometimes the nerves get brushed aside, and sometimes they get angry or go to sleep for a few weeks. So I tell my patients for a few weeks, that's very common when we do platysmal surgery, or even just platysmal surgery or subplatysmal surgery. It's very common to have some asymmetries for that, but that typically resolves. Can be permanent, but it typically resolves. So, in summary, there are different ways to do neck and jowl lifting and elevation. In my practice, I believe that a clean, crisp, firm, well-defined chin and neck and jawline is a desirable feature for both women and men. I think it serves as the foundation for a beautiful face, for a handsome face. You can have a facelift along with the neck and jowl lift. You do not have to. You can have what you want. We need to look at your pictures together from today. We can look at your pictures from years ago. We can go over your vector computer images, and we can custom design an approach for you, hopefully helping you to achieve your goals, because you can have the approach that you want, and what is most important is not what I think you need or what I think you want, but actually is what you want. If you come into my office and You tell me that you want something that I disagree with, I will tell you. In certain circumstances, I'll suggest that you go somewhere else. But I think that communication that goes on during the consultation, during the first 1 or 2 visits, about what you want, what about the changes that you want to make, I think are very important for you to tell me, to transmit and convey, and for me to hear. If you'd like any more information about the natural neck lift or neck and jowl lift or facelifting, I hope you'll call my office here in Monterey, California, 831-646-8661, or go to my website, drmorwood.com. That's DRMORWOOD. We're going to take a very brief pause for a very good cause. We're coming right back. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. Here in California, we all love the outdoors. Golf, tennis, going to the beach. However, the sun can play havoc with the delicate skin on the back of the hands and neck. Call or click today to learn the newest methods for restoration and beautification of the hands, neck, and other areas affected by the sun. Welcome back to the Doctor Is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California, with Pebble Beach and Carmel, Carmel by the Sea, Carmel by the Point, and Pacific Grove. I'm delighted you could join me for this next segment. What I'd like to discuss is the all-important decision-making progress when planning your breast augmentation. First of all, one of the most common requests that we receive as plastic surgeons, certainly in my office, and I think that's true nationwide and probably worldwide, is when a woman comes in who wants her breast to be bigger, fuller, rounder, and sometimes higher. I hear oftentimes that a woman will say, all my sisters and my mom had big, full, round breasts. I have small breasts. Sometimes women come in and they say, I really liked being engorged when I breastfed, and now that the child breastfeeding is completed, I feel like I've been deflated and my breasts are kind of loose. I think those are two of the most common scenarios that I hear, two of the most common requests that I hear. So in summary, there are two major ways that we do breast augmentation in this country. Very briefly, the first way is sometimes called the natural way of breast augmentation. That's with a woman's use of a woman's own fat. What that involves is liposuction, say of the arms and the tummy, sometimes the waist and flank, sometimes the thighs, outer thighs, inner thighs, wherever a woman feels like she maybe have too much excess fat. And instead of discarding that fat like we do with typical liposuction, we concentrate the fat. We sometimes centrifuge it, we can spin it down, we can decant it, remove that excess fluid that doesn't help, and those concentrated fat cells we can graft. We can graft those to the breasts, we can graft those to the buttocks. You've probably heard of the Brazilian butt lift. We can graft those fat cells to the chin or to the cheekbones. We can help to restore the volume loss of the face that occurs with time. We can graft those fat cells to the back of the hands. So the so-called natural way of breast augmentation, fat grafting, can be done. I would say in general, you can expect a modest improvement in the size of the breast, as opposed to when we do breast implants, you can have a modest improvement if you'd like, but I think that to get a large breast augmentation is probably more straightforward, probably more dependable and reliable with implants, which is the second most, or I should say that's the second commonly offered way of breast augmentation. That's breast implants. So there's a use of a woman's own fat, and there's the use of breast implants, both resulting in an augmentation. So what are some of the decisions to be made when planning out your breast augmentation? First of all, there are 4 different incisions that can be made. Most commonly, and in my practice, most commonly, there's the inframammary fold incision. That's a short incision between 4 and 5 centimeters in length in the fold underneath the breast. There's also the axillary approach. That's when an incision is made in the armpit or right at the junction of the pectoralis muscle and the axilla or armpit, and then that way we can dissect under the breast tissue, or we can dissect under the pectoralis muscle, and we can insert a breast implant that way. I would say that's a certainly less common approach for breast augmentation, probably because studies indicate that asymmetries can be more common with that approach. But for certain women, that can be a good approach. The other, I say less commonly used, is around the areola. That the nipple is the projecting part, of course, that's the nipple that projects, and surrounding the nipple, that's the tan part, that's the areola. So the nipple areola complex is at that center portion of the breast. So there are different incisions around the nipple and areola. One of the incisions that I sometimes make is a curvilinear infraperiareolar incision. That's a curvilinear incision right where the tan part of the areola changes to the more pale skin of the breast. We can use that incision to gain access. If a woman is going to have a breast lift and we make that periareolar incision, oftentimes we'll make a vertical incision, and that leaves kind of a lollipop scar or a tennis racket scar, the tennis racket incision. Oftentimes through one of those incisions or through part of those incisions, we can also insert an implant to do an augmentation mastopexy, which not only makes the breast bigger and fuller and rounder, but it also elevates the breast gland and nipple areola complex. The fourth way that we can gain access to the breast tissue is probably the least commonly used approach in this country, and that's the transumbilical breast augmentation. In other words, going through the belly button. Or if a woman is going to have a tummy tuck, at the same time that we do a breast augmentation, we can keep on going with our undermining or loosening up the skin of the belly, and we can go all the way up to the breasts and insert the breast implants that way. I would say the so-called transumbilical breast augmentation is the least common way we do breast augmentation. One of the reasons is because a saline implant comes empty and it has to be rolled up and placed into a metal tube like a cigar. And the manufacturer is concerned that that's going to be sort of hazardous to the breast implant. It can be punctured, it can be torn, and oftentimes the warranty is sort of voided if we do that approach. So again, in summary, the most common approaches are inframammary fold incision, I think followed by the armpit incision, followed by some variation of a periareolar incision, followed by certainly the less common approach is the transumbilical approach. So those are decisions. That's one decision to be made. Now, the next decision to be made is where to put the breast implant, above the pectoralis muscle or under the pectoralis muscle. That can be a somewhat complicated decision to make that I like to help my patients make. In general, the rule of thumb, so to speak, we use something called a soft tissue pinch test. We need about 2 centimeters being able to be pinched between the thumb and index finger of tissue overlying an implant to properly sort of disguise the implant, shield the implant, minimize the effect of, say, rippling and ripples. So if a woman has at least 2 centimeters of skin and subcutaneous fat and breast gland, then in general, it's an okay idea or satisfactory to put a breast implant under the breast tissue itself. In other words, above the pectoralis muscle but under the breast tissue itself. If a woman has thinner than 2 centimeters in the soft tissue pinch test, almost always we will recommend that we will go under the muscle. In other words, regardless of whatever incision we choose, we can elevate the breast tissue off the pectoralis muscle to insert an implant, or we can elevate the muscle, the pectoralis muscle, off the ribs and put the breast implant in that way. That's called a submuscular pocket. There's also some variations, dual plane. This morning I did a dual plane approach where I loosened up or disconnected the overlying breast tissue, breast parenchyma from the pectoralis muscle just for a few centimeters up to the nipple areola complex. And then I didn't keep on going, but I backed up, and then I went under the pectoralis muscle to create the pocket. I put the implants in under the pectoralis muscle, and what that allowed, that undermining or separation of the breast gland from the pectoralis muscle, what allowed is for that breast gland and nipple to be elevated slightly. And so what that did was correct some ptosis, or droopy nipple or areola complex, some droopy breast, without making an incision on the outside of the breast. So that helps with that. It allows us to mobilize to a much more attractive position, the nipple areola complex. So there are certainly pros and cons to going under the muscle or above the muscle. I can give you a general rule. Saline implants in general go under the muscle. Silicone implants can go above the muscle or under the muscle, above or under. And that's something that we need to discuss based on your desires, based on your size. Your soft tissue pinch test is going to be key. The position of your nipple areola complex, whether or not you have some ptosis. In general, if we put an implant underneath the breast tissue, you'll get a little more lift than you will get if we put your implant in under the muscle. If we think of a little girl on a swing, so as she swings, if the rope going to the swing is up and down, she's at a relatively low position compared to the ground. As she goes forward, the swing goes higher off the ground. So if we think about that principle as we move anteriorly or forward, how the swing goes to a position higher above the ground, it's the same way with the nipple areola complex. If we're lifting or augmenting that breast gland, it will go to a slightly higher position and therefore get some automastopexy or automatic lifting. If we move the muscle forward and the breast gland, you won't get as much of an upward transgression or upward mobilization of the nipple areola complex. Also, if a woman has some ptosis, a little bit of droopy skin, or a low nipple areola complex, if the implant is at a certain point on the chest underneath the muscle and the nipple areola complex is lower than that, that will be a less attractive breast. Sometimes that can lead to a double bubble phenomena. There are many different ways to get the double bubble phenomena. But in general, we want your implant to be at a position to bring the nipple areola complex at its maximal projecting point at about 2/3 of the way down from the top of the implant. In other words, we don't want it exactly centered over the implant. We want your projecting nipple areola complex about 2/3 of the way down. That's been studied by plastic surgeons, and that leads to the most attractive breast, the most natural appearing breast. So we talked about the incisions. We talked about the placement above or below the muscle. Now, what about choosing silicone or saline? There are real differences. As I said, saline tends to go under the muscle. Silicone can go above or under the muscle. There's no question about the safety of saline. If a woman leaks a saline implant, she's just going to go flat in 1 or 2 days. In fact, that's what some plastic surgery offices call it. A woman gets a flat, and that means that there's a leak in the saline implant. It just gets absorbed by the body. She might pass her water, go to the bathroom a lot for a couple of days, but she'll notice that one breast is smaller than the other dramatically. If a woman has a leak in a silicone implant, she may not even know it that day. The silicone doesn't spill all over the place. It doesn't get absorbed into the bloodstream, etc. Now, if a woman does have a silicone leak, I recommend that it be changed, that implant be changed. It's not an emergency. It doesn't have to be done that day. But I certainly encourage you to see your plastic surgeon, plan it out, pick a time on your calendar when you can rest and take it easy for 3 days and 3 nights. Limited activity for another week, and then on day 11, go back to your normal activity slowly. I recommend you plan that out, but I don't recommend allowing a leaking silicone implant to just stay where it is and slowly leak the silicone. Now, it's certainly true that there's no evidence that a leaking silicone implant will cause rheumatoid arthritis or autoimmune phenomena or lupus or anything like that. However, the leaking silicone does get sponged up by the breast tissue. It can go to the lymph nodes. It's not good for the local tissue. It sets up an inflammatory process. It can lead to enlarged lymph nodes. It can make a difficult breast exam. So I recommend, if your silicone implant leaks, to remove it and change it and get a fresh new one. Now certainly the new type of silicone implants, high cohesive gel, much different than the old silicone. Those old silicone, commonly, if we would take it out of the package in sterile in the operating room and put it on a surgical towel or surgical paper, and we'd pick it up and there'd be a little light oil film. That doesn't happen anymore. With the new silicone implants, the gel is cohesive. We can show you pictures where we take a scissors, surgical scissors or scalpel, cut right through the implant, turn it upside down, and it doesn't go anywhere. It stays where it is. And of course, there are different viscosities, different cohesive feeling, how firm the silicone gel is. And that's something that we can help you select. Silicone or saline. Saline can be placed through a smaller incision because they come empty. Saline can have the real advantage if a woman has a tight inferior pole, like if she has a constricted breast. A saline implant can lead to her advantage because it helps to stretch out that soft tissue. It's a little heavier. It stretches out the soft tissue a little more than silicone does, actually a lot more than silicone does. It's so we can use that to her advantage. Now, what about choosing your size? Implants come in almost unlimited sizes, although we cannot predict a cup size. That's a personal decision. There are different ways we can help you choose your size, different methods. I use the biodimensional approach. I like to encourage a woman to balance out her silhouette. We take some pretty sophisticated measurements of the breasts and the chest wall, and we take her measurements, the waist, the widest part of her hips, her bust size, and we can give you different recommendations. In general, for saline implants, we can offer you a small, medium, or large augmentation. For silicone, we can offer you small, medium, large, and extra large augmentation. And again, it's a custom designed approach. There's lots of different sizes available, but it's a personal decision. I think choosing a size is a personal decision for a woman. I think choosing between saline and silicone is a personal decision. Saline are less expensive. Saline tend to leak more. Silicone are more durable. But of course, silicone tends to feel more like natural flesh. The edge of a saline implant kind of feels like a water balloon, especially in the lower outer pole. There's a little crinkling feeling. It doesn't bother all women. It bothers some women. Silicone tends to feel more like flesh. We used to tell women that capsular contracture occurs more often with silicone implants. That's when the normal scar tissue around an implant will start to get thick and heavy and tighten and contract. I'm not sure that that's true anymore. It may be true, but there are other ways we can minimize your chance of getting a capsular contracture. Where we put the implant, the type of implant, how it's inserted, antibiotics, proper hemostasis, washing out with antiseptic solution, etc. Finally, very briefly, there are smooth implants, there are textured implants. In general, I don't use textured implants anymore. They used to be sold as a way to minimize or lessen a woman's chance of capsular contracture. I don't think that's true anymore, and some textured implants can set up an inflammatory process that can degenerate. We certainly don't want to do that. There can be teardrop-shaped implants. Those tend to be more cohesive or firmer, the sort of gummy bear implants. I tend to use a lot of round silicone implants. I think in the upright position it's hard to tell the difference. I think they're a natural look and a natural feel. So those are some of the decisions to be made when planning out your breast augmentation. And there are many of them, and I can help you to make those decisions, but there are two personal decisions for you to make. The choice between saline and silicone, and what size you desire to be. If you'd like any more information on breast implants, breast augmentation, or any other topic in plastic surgery, I hope you'll call my office, 831-646-8661, or go to my website, drmorwood.com, drmorwood, right here in beautiful Monterey, California.
This is the Doctor is in Television program. Thank you, David. Thank you, Michael, in the control booth. I hope you'll join me another time. Thanks very much for viewing.